And it's
Sorry.
Oh, you're fine. So it's discussing the differences between when something should be coded as a foreign body versus when it should be coded as an implant. And so it's telling us that if an object is intentionally placed by a physician or another healthcare provider, and it would be considered an implant if it's intentionally placed. Now, if that intentionally placed object happens to become dislodged or it moves from its original position, it becomes structurally broken, it's not serving its intended purpose anymore. For coding purposes, we would code that as a foreign body at that point, unless, of course, there is a more specific CPT code that describes the removal of the implant, and there are some CPT codes that do. But also, if an object is unintentionally placed, so say, for example, a patient accidentally ingested something, that would be considered a foreign body. Next, coding guidelines for the musculoskeletal system. And so they did a few things here. So they revised the treatment guidelines. So as far as like with the fracture treatment guidelines, they basically updated to indicate how the codes are structured. So the codes will be structured basically by the type of the treatment and then the type of the stabilization, and not necessarily the fracture itself. And they added a new section for the cast and the splint and the strap guidelines. So they just kind of moved it in the chapter set. So these have been moved to precede the musculoskeletal system chapter instead of being after it. And then we did have revised definitions for closed, open, or percutaneous. So with this guideline, it's saying that if the person, so the provider who's providing the initial treatment, and they're not going to be providing the subsequent treatment, it would be appropriate for that provider to append the modifier 54, which is for surgical care only, to the fracture or the dislocation treatment code. So an example of maybe a time when we might see something appropriate for this, maybe a patient goes into the ED and they have a radial shaft fracture, and the ED provider is providing that care, but they're not going to be providing the subsequent care. It would be appropriate in a situation like that to append that modifier 54. Our last guideline, again, this is for musculoskeletal system, but it's for the arthrodesis. So it's basically saying that if the decompression for the arthrodesis is performed on the same vertebral segment or interspace as a posterior lumbar interbody fusion, and it includes a laminectomy, a fascectomy, or a foraminotomy, these can be reported separately by using the 63052 or 63053. However, if the decompression is performed solely just for that interspace fusion, it would not be reported separately. Okay, so now we're getting into our new codes, and our first chapter here is evaluation and management. So we did have 5 codes that were added. There were 10 codes in the evaluation management section that were revised, and we did not have any codes that were deleted. So the first evaluation and management code, they didn't actually do much with this. They just removed some of the phrasing. So 99211 is the lowest level of established patient care. And pretty much they just removed the usually presenting problem are minimal from the code description. And mostly that was to be more consistent with the E&M changes that we saw in 2021, where they're more based on the number of complexity in the medical decision-making. So the next area in our E&M, so complex care management and chronic care management they're not necessarily new concepts, but the principal care management piece is. And so with chronic care management and complex care management, these types of E&Ms, they require care of at least 2 or more conditions. And so this kind of left a gap in coding because patient could just have one condition or one chronic condition. So it wouldn't have been appropriate to assign these different levels. So now we have these new principal care management that can really incorporate where that gap used to be. And principal care management, so the 2 new codes that we have there, the 99424 and the 99427, these are actually replacements for HCPC level 2 codes that actually used to be G codes. So you may have seen them before. They were reported with G2064 and G2065. Okay, so this is an add-on code, and this is for the chronic care management services, so 99437. And this is for when a provider is doing each additional 30 minutes with a patient. And so it's used in conjunction with the 99491, which is for the first 30 minutes of treatment. And then we do have some inclusion notes here. It says, do not report the add-on code unless a full 30 minutes or more is provided to the patient. And just another little note down at the bottom. So the CPT, if you do have a 2022 CPT book, if you go in it, you will see that CPT did add a table for reporting these types of evaluation and management codes. And it delineates between the time spent with the patient versus the staff type, whether it was a physician or a clinical staff. So what are the required elements for principal care management? So here's kind of where these new codes kind of became included, because as we know with the other ones, they had to have at least 2 problems. So with principal care management, the only requirement for the principal care management needs to have 1 complex condition, but this condition is expected to last at least 3 months. And it does place the patient at significant risk for hospitalization, functional decline, or even death. And the condition does require continuous monitoring and development or revision of the patient's care plan. It also requires that the patient has frequent adjustments in their medication regimen. And there has to be ongoing communication between the providers and then with the patient as well. And so here on the next slide, we're going to see more of those principal care management. So 99424. So this is for evaluation and management service for a single high-risk disease, and that's for the first 30 minutes, and that's by the physician or a qualified healthcare provider. And then the code beneath it would be the add-on code if it was each additional 30 minutes. And then the code below that is for the single high-risk disease, but it's performed by clinical staff and not actually a physician. And again, we have our add-on code there for the each additional 30 minutes. Okay, now we're moving into anesthesia. So we had 6 codes that were added. We did not have any codes that were revised, and 2 codes were deleted. So on this slide, we've got our 6 new codes here. And these codes all pretty much, they identify the type of the surgical procedure that's being performed, whether it's, a destruction procedure by a neurolytic agent, if it's drainage or aspiration. And then it further goes on to break them out by the site. So whether it was cervical or thoracic or lumbar or sacral. Here's our 2 codes that were deleted. And these 2 codes were actually deleted because they were replaced with the more specific codes that we saw on the last slide. And we will note as we're going through the presentation, the majority of the codes that were deleted either were deleted because they're now being captured in a new code set or a new code that was created, or they were just deleted because of lack of use. Okay, so now we're moving into the integumentary system, and this is pretty short. We did not have any codes that were added. There was just one revision to one code, and that is the 11981. So the revision of the code is for the insertion of the drug delivery implant. And so the term non-biodegradable was deleted from the previous code descriptor. And that's because the terminology didn't really adequately describe when a patient had a bioresorbable or biodegradable implant insertion. And so they've just revised the wording in this code to include that as an option as well. And then, of course, there's a little bit of an includes note down here that says if there was a removal of those drug delivery implants, you would actually use the report unlisted code 17999. All right. Okay, so the musculoskeletal system. So we didn't have any codes that were added, but we did have 8 codes that were revised and 1 that was deleted. So here's our first code, the deletion of 21310. And this is for the closed treatment of a nasal bone fracture without manipulation. And this code was basically deleted because the code below it was revised to include with manipulation without stabilization. So CPT is telling us if you did have a situation where the patient had closed treatment without manipulation, it should just be reported as an E&M code. So now we're moving into those codes that were revised, the 8 codes that we have revised. So really what they've done here with all of the arthrodesis codes is that they've revised the term level to include inner space. And so, for example, we've got the 22600 arthrodesis posterior and posterior lateral technique, single level inner space. And then, so all of the codes we're going to see are going to have that single level inner space wording included. And again, if you do have a new CPT book, you'll see that CPT actually added a lot of different diagrams as well as descriptions, particularly around the arthrodesis. So it does explain those inner spaces in there very nicely, as well as it gives a lot of diagrams. So respiratory is pretty short and sweet. We didn't have any additions, revisions, or deletions. Moving into cardiovascular, we had 8 codes that were added, and 2 codes were revised and 2 codes were deleted. So starting with our deleted codes, the 33470 and 33722. These codes were pretty much just deleted because of lack of use. And now we're moving into our new codes. And these are 3 new codes, and they're for the exclusion of the left atrial appendage. And so I do have a nice little diagram down here, a little picture. So we can see this little, in this area, this is the left atrial appendage. And occasionally what can happen in some patients is that blood can actually collect in this appendage. And when that happens, patients tend to get clots, which could lead to strokes. And so in these procedures, what the providers are doing is they're going in and they're kind of putting in like this little stent balloon that's actually blocking off that appendage so that that blood cannot collect in that area. And so here's our new codes for this procedure. It's broken out, so it's either open or thoracoscopic. And another new code, so this is an add-on code. And it's a procedure that would be used in conjunction with valve replacement codes. So when a patient might be having a valve replacement, what they can do is they will place these cerebral embolic protection devices, what we can see here in this little diagram. And what that does is while they're performing their procedure, once they have this little protection device in here, it stops any debris from the valve replacement from getting into these major arteries and spreading or causing clots. So 33509, so this is harvest of the upper extremity artery, one segment for coronary bypass. So this code actually used to be an add-on code. And now it's its own code. So if it's an open procedure, you're being instructed to use the 35600. And that code had been revised by adding the term open. It is modifier 51 exempt, obviously, because it's not an add-on code anymore. And if it was a bilateral procedure, we would append the modifier 50 to it.
Okay. There's a message in chat.
Okay, I can't actually access. Hold on a second here.
Question is it breaking up for everyone else or just him? Ed, not sure. Is everybody else having the same problem? Seems
Not
okay.
breaking up for me.
Oh, good. Okay.
Okay, are we good to continue?
Yes, I guess we're good to continue. Yes,
Okay.
everybody's saying it's good to everybody else. Ed, I don't know what to tell you. Sorry. Okay.
Oh, well, sometimes when sometimes when I'm presenting, I kind of move back and forth. So I know people may not hear me as clearly when I do that. But okay, we will.
Okay, okay, continue. Thank you.
You're welcome. Okay, so on our next slide, so all of these procedures for the cortication of the ascending transverse or descending thoracic or abdominal aorta stent placement, these are procedures that we're going to see most commonly performed on pediatric patients with congenital heart defects. And so the first one we have 33894. This is for the endovascular stenting. And then that includes if the stent is across the major side branches. And then 33895 is if that stent is not crossing those major side branches. And 33897 is for percutaneous transluminal angioplasty of the native or recurrent cornication of the aorta. Okay, so now we're moving into the digestive system. So we had 2 codes that were added. We did not have any codes that were revised and 2 codes were deleted. So first we have our 2 deletions here. Again, these 2 codes were just deleted because of low utilization. So our first code for the digestive system. So this is a drug-induced sleep endoscopy. And this is a procedure that can be used to treat patients with obstructive sleep apnea. And so from a little diagram, we can see here the patient would be sleeping. And so they would be sedated anyway. And then the providers can actually put the endoscope down, and they can check all of these areas to kind of determine, does this patient have obstructive sleep apnea? The next digestive procedure. So this is a new procedure. It's commonly referred to as a POEM. So you might see it listed that way in documentation, but it's a perioral endoscopic myotomy. And so what this procedure does is it actually allows some opening in here. And so it's helpful for patients who have difficulty with swallowing. So we can see here when they go in, they inject a dye, and then an incision is made in the esophagus. And then a tunnel's made in that wall and that muscular layer, and they cut it out and then they clip it. And what it does is it actually, where we can see down here where it's kind of closed, what it's doing is it's opening up that esophageal area so patients can have better success with swallowing. Now we're in the urinary system. So we had 4 codes that were added, no revisions and no deletions. So our first code here, so actually all 4 of these codes replaced category 3 codes. And so this is treatments that are used for patients that have urinary incontinence. And so in the first one, the 53451, so that's bilateral insertion of that adjustable balloon incontinence device. And it does include the imaging. And then if there was a unilateral insertion, that would be the 452. 453 is the removal of each balloon. And then the 53454 is if they had an adjustment to that incontinence device. The male genital system, so did not have any additions. There were 4 codes that were revised. And really the revision was just that they added the letter S to the term complication in these codes listed right here. And that was just to clarify that a patient could have more than one complication. And code 54352 was revised to indicate that there was a revision to a prior repair. Female genital system is, again, this one's pretty short and sweet. There was just 1 deletion. And again, this code was deleted because of low utilization. Now we're moving into the nervous system. We had 9 codes that were added. We had 6 codes that were revised and 4 codes were deleted. Here we have listed our deletions, and these codes were all deleted because of lack of use. So our first new code for the nervous system. So this is actually a technique, and it's known as visualize. So you may see that listed in some of your medical documentation. And it's laser intracerebral thermal therapy. And so what we can do with this procedure is that the providers, they can do a single trajectory for one simple lesion, or they can do multiple trajectories if the patient has multiple or a very complex lesion. And so it's really helping them with this diagnosis of those lesions. The next code, so this is actually, these are add-on codes. And these are add-on codes that we would report with posterior lumbar orthodesis. So we have 63052, so laminectomy, vasectomy, or formatomy. And it's either unilateral or bilateral with decompression of the spinal cord. And as for the lumbar, And again, if there was each additional section for the lumbar. So you'll notice that there's kind of a reoccurring pattern there in the description that only lumbar is included. And that's because these procedures are only performed on the lumbar area. So next slide. So this is a neurostimulator of the hypoglossal nerve, which is pretty interesting when we think about it. This is a new procedure that is being used to help treat patients with obstructive sleep apnea. And so we kind of think about some patients now when they have obstructive sleep apnea, they sleep and they're being monitored and they may have a CPAP machine. So this is a very neat device. And so what the providers will do is they will implant a neurostimulator. And then it has its sensing leads, and through the leads, it can sense while the patient's sleeping, their breathing respirations. And what it does is it will actually send electrode signals to the hypoglossal. And what that allows is for the patient's muscles to move so that they can actually, open their mouth there, or they can actually breathe easier. So it's very interesting to me. So we have our code for that implantation of the nerve stimulator, and then a little confusing here. So there's a revision or a replacement of the nerve stimulator. So if they're doing the revision or the replacement of the array and the distal respiratory sensor electrode, it would just be this code. Now, however, if they're doing a revision or a replacement to one or the other, so say, for example, they're doing a revision to the neurostimulator array, you would assign this code, but then you would add the modifier 52 for the reduced services, for example, yeah. And then same kind of concept with the removal. So it's either they're removing the whole thing and they're getting code, but if they're only removing one piece of it, you would use this code, and then you would have the modifier 52 on it for the reduction. Okay, so our last two codes for the nervous system. So we've got 64628 and an add-on code 64629. And this is for thermal destruction of interosseous bivertebral nerve imaging. So it's for the first two vertebral bodies, and it can be performed to the lumbar or the sacral, and then the add-on code for each additional vertebral body. Now we're going on to the eye. We had 3 codes that were added. We did not have any codes that were deleted or revised. So all 3 of these codes on the slide, these were also all category 3 codes, and they're related to cataracts. So 66989 and 66991. So this is the extracapular cataract removal with insertion of an intraocular lens. And so for 66989, this is when it is a complex procedure, whereas 66991 is more of like a routine cataract extraction. And then down at the bottom, we have 68841, which is an insertion of a drug-eluting implant. Okay, so next chapter is the ear. So we had 4 codes that were added, 2 were deleted, and 2 were revised. So here we have our deletions, and then a little snippet here of these 2 codes were deleted because they're incorporated in the description for 2 other codes. So 69716, so the implantation of osteogenic implant to the skull with the magnetic transcutaneous attachment to an external speech processor. So this is kind of a procedure that we may have been seeing already. It's commonly referred to as a Baha procedure. So you may have heard of that. So this is for the implantation of that implant here. And then if it was revised or replaced, we have the 69719 for that. If they're removing that speech processor, it would be the 69726. And then if it was removing it, the attachment to the external speech processor, so 69727. The radiology section, we had 4 codes that were added. We had 1 code that was revised and 3 were deleted. So we're starting off with our 3 that were deleted. And they were deleted because of lack of use. So our 4 new codes, and these are all for the trabecular bone scoring. So 77089, this is for the trabecular bone score. So it's including the calculation with interpretation and report on the fracture risk. And then the code below that, 77090, is just for the technical preparation and transmission of that TDS. 77091 is if it was just the technical calculation only. And 77092 is if they did interpretation and report on the fracture risk only. And that would have been performed by another healthcare provider. So pathology, this is a very large section. There was 96 codes that were added. So again, I did not add them all, but I did add a bunch. And we had 46 codes that were revised and 8 codes that were deleted. Just kind of skim through these ones. So here's some of our new codes. So pathology clinical consultation, they kind of set up something similar like they did like medical decision-making wise with like office visits. So it's kind of a similar concept. It's all time-based. And then it's, straightforward medical decision-making, moderate or high complex. And there actually is a table for this in the CPT codebook. So here's that medical decision-making grid for those pathology labs. A couple more new codes related to chromosomal abnormalities, as well as transplant medicine. So measuring patients that had allograft, maybe they're measuring their rejection on it. Bunch more new codes. We can see some new pathology codes here. And so there were some new codes that were related to COVID. And these codes, they differentiate the technique that's used for collection. So how they're collecting those specimens for COVID-19. And again, here's some more of those COVID-19 related pathologies, but these ones are included COVID-19 as well as influenza. So medicine section, again, pretty big, 36 editions. We had 4 codes that were revised and 11 were deleted. First couple of slides are our deleted medicine codes. And so this is a pretty big slide. So these are the added vaccine administration codes for the COVID-19. And it's for the 3rd dose, as well as for the booster dose and the pediatric dose. And it's also broken out by, the manufacturer. So you got your Pfizer, your Moderna, J&J, and then Pfizer pediatric. And you can get a complete listing of all of the new vaccination codes from the AMA, but there's also a whole new section in CPT, which is Appendix Q. And that will give you all of the information you need for COVID-19 vaccine administration, as well as the supply codes. We do have some new vaccines related to pneumonia, as well as we do have a few for tick-borne encephalitis virus. New vaccine for hepatitis B, as well as for Zara Ebola virus. So this first code here, the 91113. So this is another code that used to be a category 3 code. And so this is for GI tract imaging, and it's done by a capsule endoscopy, and that's at the colon. And there's also an add-on code, so 93319, which isn't related to, it's not related to the code above it, but so this is 3D echocardiographic imaging, and it's done in conjunction with patients that are having echocardiographies. And so it's usually used to, for patients that have congenital cardiac birth defects anomalies. Okay, a couple new codes again. So these are also new codes that are pertaining to congenital heart defects. And so these are catheterization codes. So we have right heart catheterization, and that's for a normal native connections. And that would be right heart if it was abnormal connections. And then the 93595 is left heart catheterization. And these ones, yeah, they continue on the next slide. So 93596, this is for right and left heart catheterization. And that's for the normal native connections if they were abnormal. And then 93598 is an add-on code to the catheterization codes to measure the cardiac output. Morning. So these are related to continuous monitoring. So we have patients that have continuous oximetry monitoring, remote therapeutic monitoring of like respiratory system, musculoskeletal system, and then supplies device for the respiratory system, as well as for the musculoskeletal system. This is the remote therapeutic monitoring 98980. And this is by a healthcare provider, and it's for the patient, and it's during the calendar month, so the first 20 minutes. So you would not report it if it was less than 20 minutes. And if it was more than 20 minutes, you could use the add-on code 98981, but it does have to be a full 20 minutes or more. And then also kind of includes note here, to be able to report either code, there does have to be at least one interaction between the patient and the caregiver. 99072, this is just a code, that providers can add when they have like additional supplies or materials above what they normally would be included in an office visit. And so it was something that was added for use for the public health emergency. Category 3 codes. So these are our new tech codes. New technology is always fun. Lots of new and interesting things. So there were 72 additions. I only picked through, and I did pick some that I thought were more interesting than others. Probably some of the ones that are more going to be more popular as well. So the first new tech code we have here is 0650T. And so this is a new procedure, and it's known as a Navicam. And so with this procedure, it's very interesting because it's a capsule endoscopy. So the patient would actually swallow this capsule, and there's a teeny tiny little magnetic camera within inside of this pill that they swallow. And what this allows the provider to do is, because it's magnetically controlled, the providers can actually move the capsule within the patient's body on their own. So it's not just kind of like going with the flow of the body. They can actually make it go up, down, sideways. They can zoom in on certain areas. So it's very interesting. Another new code. So this is for vertebral body tethering. So it's something that we would see more commonly in younger patients that have idiopathic scoliosis. So it's a treatment for that scoliosis. And so we've got, it's a fusion hardware. So you can see on our diagram here, this is kind of what it would look like just on a model, and then kind of more of what it would look like when it was actually fused to the patient's spine. And the next new code, and this is actually continued on to the next slide as well. So lots of new codes related to the treatment of infertility. So this is very fascinating, I believe, because what providers can do now is they can take a uterus from a patient, rather they're living or they're a cadaver, and they can preserve it, and they can actually implant the uterus into a mother who's struggling with infertility. And then once that mother becomes pregnant, she would have a cesarean, and then they would remove the implant or the implanted uterus, which is very, very interesting to me to think that this is how far we've come with medical technology, that we can actually do this. So I thought that was very, very interesting. And so the next codes are more related to that. And the next category 3, so this is 0707T. And so this is an injection of bone substitute material. So for example, calcium phosphate that can actually be injected into an area where like bone is not as strong, or maybe the patient had a stress injury or there's a bone lesion in that area. So what they can do is we can actually have this calcium phosphate actually injected into that area to kind of fill in the gap of where it was missing before. And so we can see these kind of procedures are going to be performed, like on the spines and the pelvis. You might see it being done on the shoulder, the hips, or the knees. So the last piece for the category 3, so it's just, so Appendix Q, that's new. So we have that listed here, and that also has our COVID-19 vaccine products. There's also Appendix R. So that's a listing of all digital medical services into different categories. So whether it's the clinician to the patient, clinician to clinician. And then there's also a piece that summarizes the provider, the service and the activities involved. So with that, that actually concludes the 2022 CPT updates. Lynn, I don't know, did you want me to share the other slide I have for, I'm just making sure we have enough time.
Yeah. If you have enough time, Amanda, just if it takes us a few minutes, sure, why not? Just show it up there.
Figure out how to get my on the top.
Sorry.
Oh no, you're fine. I'm in the share mode, but when I did that, I
Okay.
can't see.
Well, while she's doing that, are there any questions for Amanda?
I have a quick question.
Stop sharing that one. Yeah.
So when codes are deleted for lack of use, do you know what the threshold is for that?
You mean like the reasoning as to why they do it?
Well, like when they're deleted because they're not being used, like do you know like how like little they have to be used for them to be deleted?
I honestly don't know that. So AMA, CPT, they have panels. So I'm assuming they must do some research, or maybe they have statistics that they can review and say, hey, this code was only used X amount of times versus, this one that was used thousands of times. So plus also I think if, when we do have new emerging technology, older codes are probably not going to be as utilized as much because they're not doing procedures the way they used to. So I'm sure that the panel does evaluate that information. I just don't necessarily know how they do it.
There's probably a whole algorithm, I bet, because even if a code is used super seldom, if it's a syndrome or something that seemed that seldom, I shouldn't say syndrome, right? Disease, they still need that code. So I bet there's a whole algorithm to review them when they fall below X threshold of use. And then there's still probably as Amanda said, a panel to say we got to keep it anyway.
Are there any more questions?
It's a good question.
Yes,
It's a
Victoria.
good question. Yes. Brenda, thank you for answering that. You too, Amanda. Did you find that, Amanda?
I do have it.
Okay, great. Pop it up there real quick,
All right.
if you can.
Oh, I can. It's not gonna be like a presenter view or anything because but can you see my screen?
Yes.
Okay, so a little bit of a backstory on this. I included it in my slides. So CMS earlier this year, they implemented 3 new ICD-10 codes and 7 new PCS codes, all related to COVID-19. And so these new codes will be effective April 1st of this year. So we have here listed, these are 3 new diagnosis codes, and they're all related to the immunization status of the patient. So they're expansions off Z28.3. So Z28.310. So if a patient was unvaccinated, meaning they had no vaccinations at all for COVID-19, that would be the appropriate code to use. If they're partially vaccinated, meaning they have received their first dose or their second dose, but they haven't received a booster yet. Per the CDC guidelines, you're still technically considered partially vaccinated then. So that's what that code is referring to. And then Z28.39, other undetermined status. So if we don't know what their status is. So here's a little bit more information, kind of broken out really what the code descriptions are. So if the patient hasn't received at least 1 dose, that's the one that we're going to use. If they're partially vaccinated, so they have at least 1 of the next.
Excuse me, Amanda?
Yeah.
Sorry, there was a question. Is there a code for unknown or undisclosed status from the previous slide?
Yes, there is. So Z28.39. So if we don't know what their status is, that's what we would want to use.
I was just curious about that because that says other under immunization, but a person could be immunized and just preferring not to tell us or unable to tell us.
I think in Amanda's next slide, it addressed that, maybe not.
Yeah, so if they're partially vaccinated.
Yeah.
So replacement, so Z28.3. So Z28.39 actually replaced Z28.3. All other non-COVID vaccines or their current status, we don't know where they're at.
You're right, Lynn, it doesn't address it.
It doesn't really address.
It doesn't address if they.
No. You're just going to assume they're under vaccinated then. They could be totally vaccinated. We just are either unable to determine it because they can't tell us or they won't tell us.
Does anyone know if it's current clinical protocol to include this diagnostic status, or at least for primary care and surge type visits? Or are the coders just sort of trying to search this out through the history? Do you know how it's happening?
Well, these schools aren't effective yet. I don't know if there's going to be, I guess it would depend on your facility, how you would be capturing this information. I don't know. It's something that, you know, there's gonna be like training and education with the providers to make sure that they are documenting this information if they have it. And then that way we can obviously code it if it's documented. It's going to be interesting because, you know, like Lynn was saying, how would we know?
Yeah, unless
How
they
would we
give us
know?
some instruction, like they might require it for reporting to the CDC.
They
And that-
may.
And if they decide they require it, then yes, we'll have to do our best to get it, which is why I don't know why they didn't give us an unable to get that information code. If they're going to require it, we're going to need it. Otherwise, we just have to assume they're under immunized. We won't have a choice. Yeah.
Would people who are told by their doctors that they should not be vaccinated, would that fall under this code?
Yeah, they'd be unvaccinated then.
Okay.
They'd be the first one.
Okay.
The one that we're talking about are the patients who just don't want to tell us or are unable to tell us.
Okay.
And we have both of those, you know, a dementia patient or a patient who's unconscious, that kind of thing, or a patient who's just stubborn. I'm not going to tell you.
Right.
So if they're comatose then, or in a coma, then they can't tell us.
Right.
Okay.
Yeah, or, you know, it just is an unknown for one reason or another. Yeah.
I mean, yeah, I mean, that would make sense. But we don't have one, so yes. Okay, so the new PCS vaccination. So these are PCS, meaning they're inpatient only. And so these are for the introduction of the vaccines themselves. So the actual COVID vaccines. So, and then it's broken out into you know, subcutaneous, or here's the booster. So this dose 3 booster, and then it's by the either subcutaneous approach or if it was in the muscle. And so this next slide is for the introduction, and I'm not even going to attempt to say any of the COVID-19 medications because I'm horrible at it. But this is a combination of these two drugs for monoclonal antibodies. So we do kind of see, so it's by AstraZeneca and it's called Evusheld. Some people may have heard of that. And then this is this Fatisimanib, I think is how you say it. So this is a whole new medication. It's actually an oral medication that can be taken. And then just, of course, my references.
Great. Well, thank you, Amanda. That was very interesting, very informative. Does anybody else have questions for her before we leave?
I think I have a question.
Okay.
Why don't you specialize in, like, you know, mental health things, you know, autism and stuff like that? Do you remember the last time, you know, this ICD-10 code was updated to impact, you know, mental health issues? Because I think I saw a few codes, you know, on class, but I didn't see any, you know, updates, deletions, or additions to them when you were going through the list.
You mean for like COVID related or for like diagnosis related?
No, I said mental health related stuff. I mean, like, that's what I was asking about. Because
so we didn't actually have any additions. I could see. So it's CPT is broken down by different subsections. So like mental health related procedures probably would have fallen into like an evaluation and management category. Depending,
Okay.
not sure of too many. I mean, they may do procedures in behavioral health. I'm not sure of too many procedures that they do.
Right.
Usually with psych codes on the diagnosis side, they get updated if something gets updated in the DSM. If the DSM isn't getting touched, then usually the ICD-10 don't get touched. And then,
Right.
and then as Amanda said, on the CPT side, unless there's some specific services that are only ever given to that population, you wouldn't see any kind of separate codes for them. They would be under just the
They would be very
code.
specialized.
And there might
kind
be
of
some
like,
OT stuff, but no, we don't very often get that because it comes from the psych community. And then if they're not updating the DSM, which they only do every 10 years or so, we don't usually see codes for it. They did do some expansion on the autism codes, but it was like 5 years ago.
Okay, yeah. That's I know some
But we
enough,
haven't,
so.
no, we haven't seen anything new come through on that in a long time.
All right, okay, so, yeah. That's great to know because, yeah.
Mhm.
That was a good question. Is there
that's a
anybody
great
else?
question.
Yes. Is there anybody else that has a question?
Yeah, I know for RGH and stuff like that, if you have certain amount of inpatient intakes within a certain like a certain time period, like a month, they actually start for behavioral health, they start ECT treatments.
Is that a new treatment though? If it's not a new treatment, we probably had a code for it for a long time.
I don't know if it's new, but I know that it's just something that they've started doing.
We haven't seen any new
It
codes.
depends too if it's a treatment versus if it's like an actual procedure.
Mhm.
Like a procedure, when we kind of think of that, we're thinking of something that, I don't know if it's something they do in the office, something they do in the OR. I don't know honestly too much about.
If there's new medications, we'll definitely get new codes for that, but those are
Right.
in the drug code list, like that, but yeah. No, we haven't seen anything.
Okay.
Mhm.
I just wanted to mention that because I heard from one of the nurses and stuff like that worked on that floor. I was like, hey, if you didn't know this, that if you're admitted more than like 6 or 7 times.
I don't know what that would be. Yeah.
Me neither.
Yeah.
Now that you mentioned that, there were new procedure codes related to that, but that was actually in the PCS update. They were inpatient.
Mm.
So now that you do mention, I do remember the scoring, because that was hold and learn.
Oh, okay, right.
Okay.
And
All right. Well, thank you, everybody, for joining us today. Amanda, thank you again. Look forward to that Zoom meeting email tomorrow. And you should be getting, you can answer the evaluation form and get a CE for this. So
yeah, we give CE to the dues paying members of RRHIMA. And if you got an invite from Western New York, you also will get a CE. Our students don't get CE because you're students, and anybody who's a non-member won't get a certificate. So this is just a member benefit that we do, and we offer it free for our members. So most of you are, so that I'm thankful, and we love having you. So
yes.
Thank you.
Thank you again. Bye.
Thank you.
Thanks, bye.
Bye. Thank you.
Thank you.
Bye.
Okay.